free time out to do extra learning. I'm Dr. Erin King-Mullins, as they mentioned, and I was super excited when Elizabeth reached out to me because I thought this was an amazing platform and a great way for you all to learn in such a turbulent time. So kudos to you all for seeking out other ways to expand your knowledge. So I'm going to move forward with the presentation, and like I said, totally informal, laid back, throw out questions when you're ready. So let me see. There it goes. So that's me. So I am a colon and rectal surgeon. I attended med school. I'm originally from Florida. I attended med school here in Atlanta, Georgia at Emory University. I finished in 2008. Actually thought I was going to be a trauma surgeon. We did so much trauma here at Grady Memorial Hospital downtown, level 1 trauma center. And so we actually had the opportunity of having two very prominent trauma surgeons here that ended up being my mentors. And so I thought I was going to do trauma. So I went back home actually to the Orlando area to our level 1 trauma center there to do my residency. And then about 6 months in decided, whoa, this is not for me. So during my time there, I did several rotations with colorectal, with the colorectal team, because I honestly didn't even know that was a specialty when I started residency. But kind of found that I can't say I fell in love with it, but I definitely found that I enjoyed all of the different types of medicine that is practiced within colorectal surgery. And so that's, kind of what I was drawn to. And then I've come to, love it over time. And so I came back to Atlanta to do my colorectal fellowship and then stayed on with that same practice where I'm currently. So I've been in practice almost 7 years now. We actually, like I said, we have a fellowship here. And so I've a couple of years ago took on the role as research director for the fellowship here. So what I'll do now is we will kind of move into the case presentation for today. And, towards the end, when I'm done, we can definitely open up the floor to any further questions and everything more specific about, medicine and getting into residency and colorectal and surgery and all of those types of things. So this is definitely an open forum for you guys to ask me about that stuff as well. Okay, so today I'm presenting a case. It's a stage 2 colorectal cancer patient. So we'll go through kind of the history, physical, some of the differential diagnosis and the diagnostic workup that would take place. So this is a gentleman that was sent to me from oncology, 56 years old. He was actually a morbidly obese gentleman. He didn't have any acute complaints. He was asymptomatic, finally went to get his screening colonoscopy, somewhat delayed as he's 56, and he actually has a family history of colon cancer. So he probably should have started screening somewhere between 40 and 45, just depending on when that family member was diagnosed. His past medical history is significant for hypertension, high cholesterol, diabetes. Although the diabetes was well controlled, he was on significant amounts of medicines to control that. So he was also on medicines for his hypertension and high cholesterol, but notably his medicines were metformin that he took daily. He took a long-acting medicine, insulin nightly, so 100 units of that. And a short-acting insulin Lispro, 42 units 3 times a day. And that's a significant amount of insulin, especially for a type 2 diabetic. I was able to get his labs, and his A1C was actually less than 7. So while he was on quite a bit of medicine, he was pretty decently controlled. Like I said, he had a family history of colon cancer, and he was classified as morbidly obese. His BMI was 48, I think, 0.3. So, okay. So, like I said, he actually went to his GI doctor to have his colonoscopy for screening, and then a mass was found on the ascending colon. Biopsies were performed and was positive for cancer. And a further staging workup ensued by his medical team at that point. So they actually got a CT of the chest, abdomen, and the pelvis. All of that was negative for any sign of spread of cancer anywhere else. The CEA level, which is a non-specific tumor marker, but is utilized in the overall kind of comprehensive diagnosis and treatment and follow-up surveillance for colon cancer. It was elevated at 6.2. Typically normal is, and it really depends on the lab's reference range. Most people will say normal is 3 or below. Some reference labs may have it as 5 or below. And it's also important to note for CEA that smokers have a higher level of baseline CEA than the average person. So just looking at an elevated CEA in and of itself is not diagnostic of cancer, but something that you monitor over time. And so based on all of his workup, stage 2 colon cancer seemed to be confirmed. One of the things to note here is that we call this a clinical stage 2 colon cancer, which means, our clinical exam has lended toward that diagnosis. But, once someone has official final treatment, like if they have their full surgery and everything like that, whatever their final pathology is at that point, we deem that as the pathologic stage. So that has now been fully, vetted, that it confirms that preoperative kind of clinical stage. So just a little pearl there. Okay. So for this gentleman, I opted for the robotic approach, especially he had no prior abdominal surgeries. And things that really lended me towards this decision was really his body habitus, the fact that he had the diabetes with requiring, such high levels of medication, and his other comorbidities. And so one of the benefits of robotic or minimally invasive surgery is, the smaller incisions, which we'll talk about how that plays a role as we go through this case. So, and then, later on, I'll show you some pictures and videos, and we'll kind of go over the difference between laparoscopic and robotic, which robotic, the technical term is robotic assisted laparoscopic surgery. So we'll go over that stuff as well. But smaller incisions, we have decreased risk of wound infection, which can be caused by Pseudomonas and various other bacteria. The most common bacteria that causes skin, site, and wound infections after a colon surgery is actually E. coli, which is one of the normal but bad inhabitants of the colon. So using the smaller incisions with the minimally invasive approach will also lead to less pain, so less need for narcotic medicines, because narcotic medicines clearly have a risk, but besides, the risk and everything that you hear in the news about addiction, it decreases respiratory drive, and it also slows down the intestines. It helps contribute to an ileus, which any intestinal surgery already puts you at risk for. An ileus is basically just the slow movement of the intestine afterwards. So it's not a blockage, it's not constipation, but it's more so just a generalized slowing of the GI tract that happens after almost any surgery because of the anesthesia, but definitely in abdominal surgeries, intestinal surgeries, things like that. But also the smaller incisions, when you have a large incision, it's hard to breathe because taking a deep breath, when you take a deep breath, that expands the lungs, which pushes down on your belly, which causes more pain. So that's another way that having smaller incisions contributes to using less narcotics and plays a role with your respiratory efforts as well. And the robotic minimally invasive approach also decreases the risk of bleeding. So one of the things, if you kind of conceptually think about the difference between an open surgery where, you make a large incision, you oftentimes have to pull the intestines or the different structures up to the abdominal wall to be able to appropriately work on them, as opposed to when you're using the long instruments and the cameras that are inside. Those instruments are going to the location of the intestine. So you're having to move and mobilize and stretch the intestines a little bit less. There's less dissection that's required. And so that will decrease the risk of bleeding, and also decrease, again, the risk of that ileus that we just spoke about. Okay. So some of the things that are considered in preparation for surgery in someone who has, who's on medicines, or have other medical problems, typically the diabetic medications are cut in half the day before surgery, because patients are not getting typically aren't getting their full level of calories that day, so they're not having quite as high of a carb load. They're traditionally placed on a clear liquid diet, and then they undergo what we call as a bowel prep or a bowel cleanse. So they'll take a bunch of laxatives to kind of get the stool out of the colon, so it can be clean, and they'll get some IV antibiotics as well. Also to note, relative periods of hyperglycemia have less risk than hypoglycemia, because when you think about it, if someone's blood sugar is really low, just basic bodily functions are at risk, because the carbs are kind of the powerhouse as far as energy for our metabolism. And so when you add your baseline metabolism to the stresses of surgery and all of those things, and being able to heal afterwards, hypoglycemia just carries a higher risk of poor outcomes than hyperglycemia. But definitely you don't want someone's blood sugar 300. There's parameters in which you want to keep it, because high blood sugar can lead to wound infections and things like that. But when you're considering the relative risk, low blood sugar is worse. So for this patient's case, surgery, this type of surgery usually takes about 2 to 3 hours. His took 5 hours. Okay, we talked about him being morbidly obese and his BMI being over 48. And in his case, it was a lot of what we call a central obesity. So a lot of his fat was around his abdomen and inside the abdomen. And so it required quite a lot of manipulation around the fatty tissue to get to his structures. And here's a case in point where you consider, at every step in your care and management of a patient, you're going to consider the risks and benefits of the decisions that you make. So here, when we're considering the length of time of surgery, being under anesthesia and all of those, we weigh that against the being faster, yes, making a large incision and being faster, but then the patient having, increased pain, increased narcotics, increast risk of a wound infection, and being in the hospital longer. And so you just kind of have to weigh, like, oh, do I take a couple more hours on the short, up front with this surgery here, so that he has a better and shorter stay afterwards? And again, other things to consider, for example, if he had major respiratory issues, if he had COPD or emphysema, bronchitis, asthma, things like that, and his risk of being under anesthesia was greater than those other risks, then those are reasons where you may say, well, he just needs to get out of surgery as quickly as possible. So that was the decision, why to go ahead and proceed, because it wasn't unsafe. It wasn't like there was excess bleeding. It wasn't like you couldn't see at all. It was just a lot of slower manipulation of the tissue, and the progress was going well. And so as long as things are going well, you can then decide to just go ahead and continue robotically. Let's see. Yeah, we talked about all those things. Okay. All right. So using the robot, and I know this is a little bit wordy, but more of it we'll discuss when I show the videos and pictures later. But it's minimally invasive surgery. You're typically doing multiple smaller incisions. You do have to go through the fascia, so you have to make sure you close the fascia later. But again, you are leaving most of the tissues in situ at their place, and so there's a little bit less manipulation of the tissue that's required. This patient had a right colectomy, actually an extended right colectomy, just based on where his tumor was, because you want to make sure you get good margins on either side, nice healthy tissue with negative cancer at the edges, and be able to get a good number of the lymph nodes for them to examine to ensure that it's truly a stage 2 cancer. And we'll talk about the different stages momentarily. So in his case, we ended up doing a side-to-side anastomosis. So we brought the small intestine up to the transverse colon, and we were able to lay it on top of it and just kind of remove the right colon that way. That diminishes the risk of some of the internal hernias. In the right colon cases, and we'll see on the diagram later, I'll explain what I mean by that. But when you're removing the right colon, it's much less of a risk of the leak or the non-healing of the anastomosis, which is the technical name for the new connection. Whereas when we're dealing further lower down on the left side or in the rectum and things like that, there's a higher bacterial load in that area. The blood flow isn't quite as rigorous as it is on the right side because it has all the blood flow from the small intestine to those areas. You want to test for a leak before you leave the operating room. You want to make sure there's an airtight seal. And then traditionally these days, the anastomosis, the new connections are made with stapling devices that use titanium staplers, that staples that are millimeters in size and spread millimeters apart. So you really do get a good airtight seal with the technology that's created these days. People won't set off bells and whistles when they go through the airport or anything, but definitely in the future when they get CTs, X-rays, MRIs, and things like that, you'll be able to see, where surgery happened and be able to assess if that area looks healthy. Okay, so yes, so here's a picture of the anatomy. Let's see if I can, okay, I'll see if it'll let me kind of do a little drawings a little bit, or I'll use a mouse pad. Okay, can you guys see where can you guys see my mouse moving now? Okay, cool. So, so this is a diagram of the colon, okay? And so right here, this little area here is actually the small intestine. This is the very end of the small intestine named the terminal ileum. That goes into the colon here. And the very first part of the colon is the cecum, which I know you guys know this anatomy at this point, but just highlighting this because it's pertinent for his surgery. So the first part of the colon is the cecum, and this is the appendix right here. So this gentleman's mass, so ascending colon up this way, this gentleman's mass was kind of right here in the latter part of the of his ascending colon. And why that's important is that when you do the surgery resection, you want to do it based on anatomy. And so here we move forward to the next. He had an extended right colectomy. We had to go further over on the colon because we wanted to, sorry, it keeps jumping forward. We wanted to make sure we took these blood vessels with it that feed this area here, because surrounding with the blood vessels are all the lymph nodes, and you want to get an adequate number of lymph nodes for the pathologist to look at under the microscope to ensure that we are truly dealing with stage 2 disease as opposed to stage 3 disease. And so I'll pause right here and just kind of go over the staging of cancer for those who don't know. So there's 4 stages, 1 being the best and 4 being the worst. So the only difference between stage 1 and stage 2 is truly just purely the size of the tumor. 2.5 centimeters is the cutoff. And, just to put it in perspective, there's 2.5 centimeters in an inch. So, relatively small. So that's the only difference between stage 1 and stage 2. The difference between stage 2 and stage 3 is that in stage 3, lymph nodes are now involved, which is the gateway and the highway for that tumor to now spread to other parts of the body, which once it does that, it's a stage 4. And so really differentiating, especially between 2, 3, and 4 plays a huge role in the treatment of the patient, what they're candidate for, if they need chemotherapy or other additional therapies other than just surgery. So that's why when we do these, that's why, the anatomy is so important, determining, whether or not someone needs just a right colectomy versus an extended right colectomy. All of that's important to be able to get what we call as an oncologic resection, meaning a good cancer surgery to take out all the necessary tissue needed so the pathologist can fully evaluate that tumor. Okay. So, so for this gentleman, yeah, he did great. He actually was only in the hospital 2 days after surgery. and went home fine. Final pathology did confirm that it was a stage 2 cancer, so no sign of disease in the lymph nodes. And so I've actually seen him for his 2 postoperative visits already. He's greater than 60 weeks out from surgery, and he's ready to go back to work and kind of get back to himself. And so one of the things that will happen now is he'll just kind of continue with his oncologist. They'll monitor those CEA levels to make sure, number one, they'll get one soon after surgery to make sure it's fallen down into the normal range, so that as when they monitor him, if it starts creeping up, that can be an early indicator that the cancer is coming back, and sometimes can detect things before it can be seen on CT scans or MRIs and PET scans. And then he'll be due for his next colonoscopy at 1 year from surgery to reassess, make sure everything looks fine, and then he'll be on a 3 to 5 year schedule after that, assuming that that colonoscopy goes fine. So before we jump over to question and answer, I'm going to switch and show some of the videos and everything. Well, thus far, does anybody have any questions?
Yeah, Dr. King-Mullins, I had one question on the anatomical image, slide 12, I believe, that you
Sure.
had. So for just hypothetically speaking, if you were going to make an incision on the descending colon, how, based off of those arteries, like how far would the incision go? How inferior would you go, like, for the incision? Yeah.
So believe it or not, robotically, and you'll see a picture, a diagram of some of the incisions momentarily. With the newest robotic technology we have, a lot of the incisions actually end up being in the same position, because the technology of the robot is so awesome. It actually articulates and angulates and all of those things. And so it really mirrors the function of your hands inside the body. And so some people actually describe robotic surgery as minimally invasive open surgery as opposed to laparoscopic, and I'll be able to show you the difference between the two. Yeah, let me switch over actually, and it'll be able to better kind of show you the, okay. So here is, all right, so this is an old presentation that I'm gonna bring up because it has best pictures and stuff. Okay, can you guys see this?
We cannot. No,
okay.
we see the same Google Drive.
Okay, 1 second.
You might want to like stop. Yeah, so somebody asked in the chat, are there any changes in the recommendation for how many lymph nodes are adequate for sampling?
It remains 12, and it's been 12 for a very long time. However, I tell you that I will say that we have learned over the past couple of decades that the techniques for extracting lymph nodes and assessing lymph node tissue has been a lot better. And so I don't necessarily think that number will change, meaning that I don't think it will go down at all as far as the requirement of the number. But I don't, at this point, we're not at the point where we're saying like, oh, you need more, because the techniques in evaluating the lymph nodes have gotten better. Okay, give me 1 second. Let me see if I can bring up, okay. Let me go back to share screen and, okay, can you guys see this now?
Yes.
Mm-hmm.
Okay. So here is a picture of laparoscopic surgery, okay? So that's me. This is the abdomen. I'm standing at the side of the table, and these are the instruments here. Are you still seeing my pointer? Is it still showing? Okay, good. And then here's just kind of a picture inside the belly. So this is actually going down towards the pelvis. So this is the inside of the right side of a pelvis. And this is actually the rectum internally up. And then this is my instrument. And so as you see here, laparoscopic, one of the nicknames for it is straight sticks, because that's literally what it is. We're using these instruments that are straight sticks, kind of going into the belly. There's no real flexibility or articulation of it. And so while it's great to have these small incisions, it can be difficult in a few different ways. Number one, because you can't really flex and move the instruments as much, there's a lot more mobilization or moving of the tissue that has to happen to contort it in a way that that angle can be achieved, since you can't change the angle of the instrument. But also, it can, for in some instances, create, a lot of body fatigue for the actual surgeon itself, because with our articulation and the torque that has to be done at the different fulcrum and stuff like that of these incision sites, it can, just end up being uncomfortable for the surgeon, depending on if they're having, and then with the monitors being there, having to look at a monitor for a certain period of time. But definitely, beneficial to the patient in the sense of smaller incisions. So a lot of the downstream effects are the same when you're comparing laparoscopic and robotic. So here's robotic surgery. So on the left, you see me sitting at the machine, which I'm in the same room as the patient. So this is an earlier picture. I'm actually, at the, oh, sorry, it jumped to the picture first. Oh, and why did it go sideways? Okay. So here you see, these are the robotic arms that are attached to this little thing right here is called a trocar. That's the actual part that is the access to inside the abdomen, and then the instrument goes inside of that. And then this is a picture of the robot instrument and arm kind of going inside of that. And so let me escape for a second, because for some reason this video turned in the wrong, oh, okay. For some reason when it was bigger. Okay, so here's a picture of a video. Why did it do that? Let me see if I can get it to. I don't know why it's doing that. Let's see. Did the video play for you guys?
It did. Oh.
Let's see if I keep rotating it, if it'll do what it's supposed to. Okay. So they're moving the robot in towards the patient, and then I'm adjusting the instruments there. Is it showing right side up for you guys? Okay. So that's them kind of driving it in towards the patient. And let's see.
In this specific case, how many incisions were there, or like entry points?
The average is 4 to 5.
And then the camera, is it on each like straight stick, or is that its own incision?
So yeah, so there's multiple of, there's each, they have multiple incisions. So each instrument goes into its own incision. So there's like one incision where the camera goes in, and then depending on which exact surgery you're doing, you'll need 2 or 3 other incisions for the other instruments. So, and then you typically need 1 more incision for an assistant. So there's someone physically still, like while I'm operating at that machine off to the side, there's still someone standing at the bedside to, number 1, help switch out instruments. They can remove tissue, they can pass me sutures so I can do, suturing inside and things like that. They can help irrigate or wash things out, suck any blood that's in my way and stuff like that. Let's see. All right, if this video is going to play. So this is me. Again, I don't know why it switches. Okay, let's do this. Let's see if it'll behave. Okay, so this is actually just attaching the robot to those trocars that are on the belly. Okay, and then am I going to have to do the same thing? So this is going to be a video demonstrating how the robotic instruments are now inserted into. Okay. So we're watching on this monitor up here as we're guiding the instruments on the inside so it can go to the right place in the belly and it doesn't injure anything. Okay. I'm just going to go ahead and do this because it's probably going to go sideways again. All right. So this is kind of a demonstration. I'm over here in the corner operating. This is the machine. You can see like this is moving. So it's mirroring what my arms are doing. And then this is what's actually going on inside the patient. Okay, let's see. Do we have any more? And then we have one more kind of, will be like a zoomed in picture of reflecting what the instruments are doing. And this will be able to better show you what I meant by how the robotic instruments can truly like mirror what your hands do. So once it's inside, they have these joints on the inside that can then move an angle. So as I'm on the machine, like if I go like this with my hand, the instrument literally does that. If I go like this, so it truly is, you know, the machine is mirroring exactly what I'm physically able to do, as opposed to, you know, the chopsticks type movement of the laparoscopic. All right, let's see. Okay, so this is the stapling device, and this going straight up actually is the rectum. We've got fatty tissue on either side of it that we had to clean up. And so this is now, and this is the stapling device that's squeezing across the tissue. So that stapling device is going to squeeze down the tissue and then cut it, but it staples on either side and cuts in between. So it's going to be closed. So poop is not going to leak out or anything like that. So it fires two lines of staples first, and then it cuts in between. So it's sealed off. Okay. And that's me just kind of disconnecting it. So that's the stapling device there. Okay, so in that picture, if we go back to this diagram, I was stapling off right about in, wait, never mind. You're not seeing the other slideshow, are you? Okay, hold on. Let me stop share and switch over to the other one. Okay, we back up to the, okay.
Yes.
Okay, so in the video that you just saw, this is the rectum down here. And so this is where I would have been stapling across. So if that person, I can't remember exactly what that person's case was, if it was a cancer or like a diverticulitis or something, but basically in those cases, we staple off the rectum right here, and then we divide, you know, somewhere up here. And then a stapler comes actually, once that part's done, a stapler will come up through a circular stapler, as opposed to that sideways one. It's one that's kind of end to end like that. And so part of the stapling device comes up through here, and it's able to now attach this down to there in a straight line. So that would have been kind of the conclusion of the video that you just saw. Okay. All right, so that's this case.
All right, so we have somebody said, wow, technology. But we have one question. It says, so if you clamp your hand together, the robot will clamp down I think that they're asking about how the stapling is worked when you're sitting.
Gotcha.
Yeah. Mhm.
So there are, let's see, actually, I'll see if let me go back to one of the other videos. Okay, so in this picture down here, there are foot pedals, and these are my controls to do certain things. And so when an instrument is put into a certain arm, inside where my head is, you direct it to, it directs you to push one of these buttons. So you put your foot down on one button and it'll close it and clamp it down. And then you click on a different pedal kind of up here to then signal it to fire it and actually cut it. And so the benefits of that is, you know, when you clamp across it, if you don't like quite where it is, you can still open it back up and readjust and do all of those things. So each step of the process of stapling and then closing and firing is controlled by different pedals.
I guess one question I had was, is there a significant time difference versus like doing it either by hand or doing it by the robot? Like, is there
Sure.
cut time basically?
Yeah, there's typically at baseline roughly an hour difference, 45 minutes to an hour difference between the two. But again, some of the things that come into play is really when you're considering length of stay, what the patient's medical problems are, or what the surgery is as far as how much you're going to have to move the tissues around. So those are the things that you kind of really consider. Also, another thing, you know, again, especially when you're kind of maybe deciding between laparoscopic and robotic, laparoscopic requires a lot of assistance. Someone has to hold the camera up in that position. Let's see here. Yeah, so this person over here is holding the camera inside. And so obviously there's, you know, fatigue that can go along with that. You know, if you're holding your arm in one spot for an extended period of time while I'm doing the dissection, you know, mobility and things like that, or, you know, so one of the benefits to the robotic surgery is like, I literally have control of all of those instruments. So I activate a button and I can pause one instrument over there and hold up, I can lift up a part of the colon that's in my way and then just let it sit there. And then with a click of a foot button, I can switch over and now that'll just stay held up like that. And so I technically have 4 hands because again, I direct the camera in one spot and it just sits there, the machine holds it there, and then my 2 instruments are working. So my 2 instruments are working while the camera's still and that colon is held up over there. So it puts a lot of the control in the surgeon's hands to be able to direct the vision, the line of tension, the mobilization, you know, where it needs to go, and it relies a little bit less on the assistant.
What did your training look like for robotic or for laparoscopic?
So now it's a little bit different. Like, so for me, we did quite a bit of laparoscopic, you know, during residency, which I'm sure, you know, anybody now going through any surgical field, you know, lots of laparoscopic. Robotic, we didn't really do too much here. Like I had some robotic stuff when I was a resident, but not with colorectal stuff, mostly with some of the different specialties like the bariatric folks and the thoracic folks. So I kind of had the basic techniques of it down as far as like how to actually use the robot. But I decided once I went out to practice, you know, when you first start out, you're not necessarily busy. Not everybody's sending you all the big cases because you're brand new. So I just took that time to say, hey, I'm just going to go, you know, hard and fast and team up with my robotic representatives to, you know, just learn it as much as possible because there is a learning curve to it. You know, my first couple of cases probably took me 6 hours, 7 hours. But as you know, continue to grow and get used to it, you get that time down. And so since I really didn't have a whole lot of time to do anything else early on, I just used that time to, you know, kind of perfect the craft. And so that also allowed me to now I'm pretty comfortable doing like, you know, anything that can be done robotically that way. You know, there's always going to be cases that can't be done robotically or laparoscopically. If someone has an intestinal obstruction and their intestines are really swollen, or it's an emergent abdomen, there's always going to, or if they've had multiple abdominal surgeries and they have tons of adhesions that you're not even going to be able to safely get those instruments in there without injuring anything. There's definitely always going to be cases that can't be done laparoscopically or robotically. Sorry, give me 1 second. I think my baby just woke up from her nap. Okay, sorry, we're good.
That's okay. That's
You're good.
okay. I'll just use this moment to ask if anybody has any other questions. Feel free to unmute yourself or just drop it in the chat. And are you willing to take questions about your schooling, your journey? Yeah. If anybody has any questions, yeah.
I just had another question about like the robotics. Like, how did you end up getting into doing the robotic surgery?
It was kind of one of those things. Also, like when I came out into practice, like at that point in time, still not everybody does robotic colon surgery. And so I had to make the decision on how I was going to better market myself to get busy and to become, a known surgeon in the area. And so being able to offer that technology to patients, and then being able to go introduce myself, to other referring physicians and things like that. But also just kind of what I saw that the technology was able to do for the patients, right? Like, especially in that case that I just did. I mean, man, that guy would have probably minimum have been in the hospital for a week if I had to do a large incision, because you do a large incision like that, their pain is crazy, their ileus or that slow intestine is crazy. It takes a long time for them to start moving their bowels, and and then when you're having so much narcotics, they're having a lot of nausea and vomiting. It's guaranteed that his blood sugars would have been all over the place. And so really just seeing what you're able to do for the patients was a huge drive and push to do that as well.
Thank you. That was very cool.
Oh, thank you.
I had a quick question about could you go back to the slide with the anatomy? I think it was like slide 11 or slide 12. Because I just had a quick question. So you mentioned that because you had to resect so high up, because of like the blood vessels, and then, or not the blood vessels, because of the lymph nodes.
Uh-huh.
Does that mean that patient doesn't really have a superior mesenteric artery anymore because you got rid of all his branches?
No, you don't go that high. So you take the ileocolic vessel over here, and then you take the middle branch. And so you just take some of the more distal branches. Yeah. So like when you come up, you take the middle colic and the right colic, but some of the earlier SMA branches are still there.
Okay, that makes sense. Thank you.
Mm-hmm.
If there's not any more questions, we'll go ahead and we can end the session. Thank you again, Dr. King-Mullins, for taking time out of your day for us, and awesome learning experience as well.
No problem. Thanks for inviting me. Good luck to everybody. And if anybody has any questions, Elizabeth, you guys can totally share my email address, my Twitter handle or whatever. Yeah, you found me on Twitter, and just give me a shout.
Okay, awesome. All right, thank you so much.
You're
we really appreciate it.
all right. Bye.
Thank you.
You're welcome.